Thank you everyone for joining us today. It's really my pleasure to introduce our distinguished panel. We have two experts in urologic oncology. Our first speaker is Dr. Matthew Cooperberg. Dr. Cooperberg, as you know, is a leading expert from UCSF. We're also joined by Dr. Punnen. Dr. Punnen provides specialty care for patients with urologic malignancies, including prostate, renal, bladder, and testes cancer.
Great. Thanks very much. It's great to see both of you, and a pleasure to give a bit of an overview today in terms of the state of affairs for biomarkers and imaging in active surveillance. Work with a number of companies in this space, including Veracyte, who is our host today, the new parent company for Decipher. So as I'm sure most people watching this are familiar, the space of candidate biomarkers for pretty much every decision point along the prostate cancer continuum has really exploded in the last few years. And while there were no new entrants in 2020 for the first time in a few years, the space for men trying to make a decision about what to do after prostate cancer diagnosis has become much more complex. And we now have a number of different tests on the market to help men who have a diagnosis of what looks like low-risk prostate cancer decide whether or not they should get treated or go for active surveillance. And the question has now become as well whether these tests can help us tailor surveillance. And it's important to point out that the imaging tests, and in this case we're talking mostly about MRI, really play in the same space and need to be considered along all the same rules and criteria as the tissue, blood, and urine markers. Now, we had a consensus meeting at the AUA in 2018 when the AUA was in San Francisco, and just came up with a number of statements about these emerging markers as a class. And one of the key ones is that any candidate marker to be proved valuable has to improve on the best available use of the clinical information that we have at hand. It's not good enough just to improve on the baseline risk grouping systems, because we can already do that for free. So the standard of the bar that we're trying to meet is actually relatively high, and I'll show you that in a minute. Now, by how much you need to improve in terms of a C-index or an AUC, that is not necessarily clear, and the answer is often it depends, depending on what exactly the marker is trying to do. And how to integrate markers with imaging is a completely unanswered question for the most part. Now, like I said, we can do a pretty good job with the basic clinical information at hand. This is the Capra score, which is now about 15 years old. We published that at UCSF a long time ago, looking at very basic information: Gleason score, T-stage, percent of cores positive. We can risk stratify with these very basic clinical parameters with about 85% accuracy, looking at long-term cancer-specific mortality. And we can do even better with other parameters that we have for free at the point of care, like PSA density, like PSA kinetics, the extent of Gleason pattern 4, and increasingly focusing on these pathologic subtypes of pattern 4, like fused or poorly formed glands versus cribriform and expansile cribriform, being indicators of progressively bad prognosis within pattern 4. And so with this context, though, the fact of the matter remains that we're still using risk groups which are to a large extent outdated. This is the update on the NCCN risk groups. I would defy anyone listening to this to even rattle these off from memory. Once the slide goes off, it's become a very complicated risk grouping system. There are actually different criteria in each of these boxes, which is the first sign that this is a so-called camel, a horse designed by committee. These kind of came up by consensus, not because this is any sort of programmatic way of thinking about risk. This is nonlinear, it's very cumbersome, and there's a huge amount of heterogeneity within each of these boxes. So saying we can do better than the AUA risk groups or even the NCCN risk groups is really not good enough, because we can already do that with any one of a number of nomograms, Capra score, etc. Furthermore, it is increasingly safe to say in 2021 that active surveillance really is standard of care for low-risk disease, pretty much full stop. Now, there are details here. This is the AUA Astro-SEO guideline. There's another guideline from ASCO endorsing the Cancer Care Ontario guideline. Surveillance really should be pretty much the only treatment for men with so-called very low-risk disease. It's preferable for most low-risk disease, whether or not you can check all those boxes for very low risk. Definitive treatment may be offered selectively for some men with low-risk disease who are at high probability of progression based on other factors, and this is where the biomarkers may come in. And furthermore, surveillance may be offered to select patients with intermediate risk disease, and this is where biomarkers definitely play an emerging role. So pathologic Gleason grade group 1, if you know that all you have in the prostate is Gleason grade group 1 or Gleason score 3+3, these basically do not have the molecular hallmarks of cancer. They essentially never metastasize. And if you knew for a fact that this is all you had and all you would ever have, you could pretty much stop worrying about your prostate. The issue is about what is the risk of undersampling and what is the risk of progression over time. Now, as I said, a lot of the interest now is in this so-called favorable intermediate risk group, or the low volume Gleason 3+4s. And the thing is, these are quite heterogeneous. And within what we call NCCN intermediate risk, or even favorable intermediate risk, there's a lot of heterogeneity. These are two patients who we can all tell at a glance have a pretty substantially different biology and risk of progression. And yet these both fall into this favorable intermediate risk box. We can do a slightly better job categorizing them using something like the CAPRA score. We can do an even better job by, again, adding in some of these details like the subtype of pattern 4, the PSA density, etc. And we can really start to think about these men quite differently. But when it comes to dichotomizing risk in terms of 3.3 versus 3.4, it gets to be quite a challenge. And the fact of the matter is this is very difficult for pathologists. When we're talking about the low volume 3+4s, when the pattern 4 is a fused gland subtype, there is quite understandably often disagreement among even very experienced pathologists. This is a study out of the Canary Consortium, which is 9 major academic centers, each with a top-notch GU subspecialized academic pathologist. And they've been trading cases back and forth for years. When one of them said it was an easy call, 3.3 versus 3.4, their agreement was in the high 70s. But the minute one of them said it was difficult, they had a hard time telling is this 3.3 versus 3.4, agreement fell to 27%. Kappa 27. One pathologist will always tend to call that a 3.3, one will always tend to call that a 3.4. There's no way to say one is right. But the fact of the matter is, what we're talking about here is often artifacts of sectioning and very subtle differences in histology rather than clear demarcations in biology between grade group 1 and 2, which makes it a difficult endpoint to use to validate a biomarker. There's been a lot of discussion lately about men with BRCA mutations and whether men with germline mutations can safely be on surveillance. There have been very few studies with any kind of substantial numbers of patients. This is out of Hopkins, which has one of the larger cohorts, although we're still talking about only a couple dozen men with BRCA or ATM mutations. And in fact, these men do have a higher risk of reclassification to higher grade disease on active surveillance. The question, though, is, does this mean they should not be offered surveillance? Well, look at the numbers. This is the likelihood of reclassification over time here for non-carriers versus mutation carriers. And yes, men with mutations, either they're BRCA1 and 2 or ATM or BRCA2 alone, are at higher risk. But the time it takes to get to a 50% chance of upgrade for BRCA2 carriers is about 5 years, 6 years for all carriers. I think the question is, does a 50% risk of upgrading in 6 years mean you should not go on surveillance? And I would say for many of these men, the answer is not necessarily. You tell me I need treatment in 6 years, and I will say, great, let's talk in 6 years. The likelihood that this cancer will actually progress to an incurable state in the interim does seem to remain relatively low for most men in this category. And furthermore, as we talk about surveillance, I think the conversation is really getting beyond who needs surveillance and who needs immediate treatment to how can we further personalize these decisions. And these are not real numbers here. These are just gestalt based on both literature and our large cohort of a couple thousand men at UCSF. And if you think about how these men break down, we typically tell men there's about a 50-50 chance of needing treatment within the first 5 years. And yes, a lot of these men do need surveillance. Eventually, we'll find a little bit of higher grade disease, higher volume disease. Maybe they'll go on to treatment, maybe they won't. There's a relatively small set who really do have bad biology, who this year it's a 3+4 and 1 core. By next year, it'll be 4+3 and 8 cores. And by the time we take them to surgery, we find extracapsular disease and wish we could set back the clock. These happen. They're uncommon enough. We can tend to picture these men's names and faces. It's probably far less than 10%, frankly. But they are out there, and we need to do a better job finding them. But there's also a larger pool of men for whom we can do a better job by doing less. These are the men whom we diagnose with low volume Gleason grade group 1 tumor, the next biopsy is negative. The next biopsy shows a tiny speck of grade group 1 again, and these men percolate on through surveillance for many years. PSA is stable, maybe rising slightly with BPH. These are not cancers the way we think about cancer. They do not progress. And these men, frankly, probably shouldn't even have the cancer diagnosis, or certainly they don't need to undergo a biopsy every year or even every 2 years. And we recently published from this same Canary consortium of 9 major centers a richer clinical model, really trying to drill down to the most we can use with the clinical data to try to help men on active surveillance do a better job tailoring the intensity of their surveillance protocol. And by looking at things like the extent of biopsy core involvement, whether they've ever had a negative biopsy after diagnosis, PSA kinetics, etc., we can come up with a multivariable model that allows us to predict likelihood of upgrading out to about 4 years. And we can identify men with a very good negative predictive value for reclassification at 4 years so far. And that time frame will continue to push out to the right as we get further follow-up in this cohort. The idea being that there's a substantial number of men whom we can't quite say go home and forget about this, but we can certainly say we can follow this from respectful distance with much less common assessments than we are currently doing now, particularly when it comes to the biopsies, but even MRI as well. Now, how are we doing with surveillance? These are data from the AUA's Aqua registry. Active surveillance in the US is now up to about 55%. This has been shown in a number of other cohorts as well. This is big progress in the right direction. It's about a quadrupling since where we were in the prior decade. There is still extreme variation, though. On the left is county level practice patterns in the SEER watchful waiting database, with the yellow bars here being active surveillance. And on the right, we have individual urologists, and whose door you knock on will give you a likelihood with low-risk disease of getting active surveillance ranging from 0% to 100%. And we know this is true everywhere we look in healthcare. This is not just a problem in prostate cancer or in urology, but of course it is a major problem, and we need to do a better job standardizing these decisions. And doing a better job with surveillance. So we worry, as I said, about over biopsying and over sampling these men, but there's also under assessment for many men as well. In the MUSIC consortium out of Michigan, the proportion of men who had at least 3 PSAs and even 1 biopsy within 2 years of diagnosis was barely over 25% across all the centers in the state. So, do biomarkers help us with all this? Well, the first question is, do biomarkers improve risk prediction above and beyond multivariable risk stratification systems? The answer is clearly yes. There are multiple papers for the major markers out there. There's literally over 100 papers now for the Decipher test in particular, validating that these markers do improve not just on the NCCN risk groups, but on a variety of well-done multivariable linear clinical tools in terms of identifying men who are at higher and lower risk of disease progression. Now, do they actually help us make better decisions for active surveillance versus treatment? Here, it's harder to say because the studies, the trials, which really need to get done are still underway. There's one called G Major happening in Michigan now, which is a randomized trial that Todd Morgan is running, which will be a fantastic source of information. But most of the studies which have been done to date tend to be retrospective and are a little bit difficult to interpret in terms of what is the true impact of the marker on decision making, never mind on outcomes. And a big challenge here is really in terms of what the outcome of interest is when you set up these studies. As I mentioned, the difference between Gleason 3.3 and Gleason 3.4 may be biologically very subtle. So trying to predict that difference with a marker, maybe asking the marker to separate apples from apples, which is a very difficult task. So in some cases, studies may get done that come up negative just because the endpoints are really challenging. This is a look at the GPS test in the Canary consortium, and in terms of predicting adverse pathology among men who were on active surveillance in this consortium and went to surgery, there is some suggestion of independent prognostic value for the marker. It kind of falls out barely in multivariable analysis, but in terms of predicting biopsy reclassification, it really was not even close. Now, is that because the marker doesn't work or because it's the wrong endpoint? I think that's really still an open question. Now, we are big fans of the Decipher test in particular at UCSF, in large part because it gives us by far the greatest information. So not only do we get the Decipher score, but the full genomic array on every test that we run. And we've been able to look much deeper under the hood in terms of the biology of these cancers, and can identify men who have what looks like low-risk disease, who really sort out into pretty aggressive biology by the Decipher score and by a number of other genomic classifiers as well. And this will really, these types of deep dives, I think, will really eventually get us to where we need to be in terms of making long-term predictions about outcomes, as well as immediate decisions about who should get treatment versus surveillance. Now, we do know from other ongoing studies, this is a prospective study in the music cohort, presented but not yet published, from Dan Spratt. Not surprisingly, men who have high-risk disease by Decipher are much more likely to wind up getting treated than men with low-risk disease, and actually to recur after treatment, having initially been on surveillance. Now, the question again, though, is, should these men not even be offered surveillance in the first place? And I think it's a bit of an open question. I would say Decipher high risk. These are men that have a high risk of actual metastatic disease even after surgery. I would really be cautious, to say the least, about surveillance, but it's not to say that it's an emergency. And some of these men may at least be able to delay for a time, because at the end of the day, none of these tests is binary, and none of them tells us really what to do. We all want a pregnancy test. Turns blue, we take out the prostate. We're not quite at that point yet with any of the tests on the market. And the fact of the matter is, some of the presentations can really oversimplify. And this is not to beat up on the GPS test particularly, but this notion of kind of reclassification according to these NCCN risk groups, which is how this particular test is presented, really can be not only confusing but misleading. And these are two actual patients who I saw in clinic 2 years ago, one of whom had actually a lower score than the other one. If you run multivariable analyses here, this patient has a much higher risk of adverse pathology, but because they started NCCN low, they kind of wind up with this lower risk compared to this man. It's all very confusing and can lead to poor decision making. This man is much more likely to go off and get treated than this one, even though he's got a lower score, low volume disease, and a lower risk of bad pathology. Briefly about MRI, the biggest challenge we have with MRI is that we're taking very rich data coming out of the magnet, simplifying that to a grayscale picture that we then put through a human factor and put into this 1 through 5 PIRADS scale, which we functionally dichotomize at the point of care, and we're losing a tremendous amount of information along the way. We've had a huge opportunity to do this better through machine learning. Sanoj has made a lot of progress with this at Miami, I know. Maybe he'll comment on this. But right now, there's too much inconsistency. Likelihood of finding high-grade disease based on a PIRADS 4 to 5 ranges from the 20s to the 70s if you look across major academic series. And these are sort of the best-case scenarios. This is too much variation for this to be our go-to. And we also did a study recently out of the UCSF cohort looking at the negative predictive value for MRI as a means to try to replace biopsies on active surveillance. And for the first confirmatory biopsy on surveillance, the negative predictive value overall was only 74%. And if there's a high PSA density, it's barely over 50%. Now, at subsequent biopsies, once you've done the confirmatory, things do look a little bit better, especially if the PSA density is low. But I don't think we're at the point yet where MRI can replace biopsy. It's a great adjunct, but it's not the best biomarker we have. Now, the last point I want to make, though, is that there's a lot of discussion about making sure we don't miss high-grade disease, both with markers and with MRI, et cetera. I want to return everyone's attention to the low-risk subset from the PIVOT trial. This was a watchful waiting versus surgery trial for men diagnosed in the 90s by a sextant biopsy in the VA. This is sort of worst-case scenario for undersampling of cancer, and yet we did not see a hint of benefit for intervention versus surgery out to about 12 years. So it is likely the case that we do not need to spend too much time worrying about missing low volumes of 3+4 for the majority of men, particularly those who are relatively older at the time of diagnosis. So to sum up, I think it's a safe statement that surveillance really should be preferred for nearly all Gleason grade group 1 tumors in 2021. Who exactly benefits from use of markers, remains a little unclear, but I think, my own personal practice, I think they're very valuable. Decipher in particular for those with high volume grade group 1 tumors, low volume group 2 tumors, and those with other factors like strong family history, maybe germline mutations, those who are very anxious, anyone who needs help getting off the fence in terms of treatment versus surveillance. The depth of data that we get from Decipher really is unparalleled in the space. MRI, as I said, should augment but not replace biopsy. And I think there is going to be a fantastic role for these markers going forward as we do the next round of studies to help us tailor the intensity of surveillance and figure out better personalized strategies from it. So I will end there and look forward to discussion.
Thank you very much, Dr. Cooperberg. Dr. Punnen, I would ask you to provide some perspective on this topic.
Sure. Yeah, I agree with much of what Dr. Cooperberg stated there. I definitely think there could be a role for these biomarkers in terms of tailoring active surveillance. I think there's definitely a subset of patients who really do have low risk disease. They're not going to progress, and you can really de-intensify their surveillance. And I also agree with the fact, his point about none of these being a binary marker. I think they can be used with clinical data, imaging data, to try and tailor that to the best way possible.
Excellent. So maybe I'll start with the first question to both of you, which is, what is your ideal paradigm for active surveillance? I know we've talked a little bit about tailoring it, but just so that the audience has an understanding of what's your essential baseline for a man who's going on to active surveillance?
I could start. I mean, so for me, I think, to me, a person really only starts surveillance for the most part after that confirmatory biopsy. So I do think, having some sort of baseline risk assessment kind of to determine when that confirmatory biopsy needs to be done or not is something. And then if that's fine, then you kind of set the stage. For me, I do tend to get a PSA every 6 months, and I do tend to do an MRI every year. No one really seems to have much of an issue with that. I think it's the biopsy that I'll kind of, space depending on kind of the risk and what the MRI and other markers have kind of suggested. So that's where I tailor it. But for me, the PSA and the MRI tend to be more fixed.
I'd really stress that point about confirmatory, and it's surprising that there's folks even in high volume surveillance centers in the academic world that don't necessarily do it routinely. I think for us, especially if somebody's had a biopsy outside of our center at UCSF, and especially if that was a non-MRI targeted biopsy, it is not remotely uncommon that we find clear visible lesion on ultrasound and higher grade disease. And there are at least a few a year that we catch who would have done quite poorly on surveillance. So the confirmatory, I think, is essential unless we have done the diagnostic biopsy at our center and it was MRI targeted. Will we skip it? Once that confirmatory is in our belts, I think things have evolved over the years. We're really trying to stretch out the intervals as much as possible for men who look like they have lower risk disease on the lower end of the spectrum. I'm typically getting an MR about every 2 years now for the kind of routine surveillance patient. But as they get older and we get more duration of surveillance, we're stretching out to 4 years. We're starting to use this canary calculator a little bit in practice. And for guys who are borderline candidates, 3, 4s, et cetera, those are ones where we really do get markers relatively uniformly, and we'll use that to try to figure out, okay, can we stretch you to a longer interval? Do we need to keep an eye on this with annual surveillance? It is a pretty rare patient where we're really going to recommend for treatment instead of surveillance based on a marker. But there's definitely men where we say, you can go on surveillance, but it's going to have to be very tight, sort of Hopkins in the 2000s style of annual biopsies.
Let me ask you both a philosophical question as it relates to surveillance and genomics. We live in a much more technologically interested community, I would say, amongst our patients. And from your presentation, Dr. Cooperberg, we see about a 55% surveillance uptake in these low-risk men, where perhaps we should be more at the 75% zone. So do you think genomics could be a tool by which to help either convince or perhaps assuage patients that are potentially on the borderline for surveillance to go on surveillance? So could we think of genomics not necessarily as its prognostic value fully, but also as a means to help in that decision-making process?
Yeah, it's a great question, great point. And it all depends on where the baseline thermostat is among both the patient community and the physician community for making recommendations. So first of all, yeah, we should be. Sweden's about 80%. That's probably where we should be. The UK just announced some data. They're at 96% surveillance for low-risk disease, but they're actually, frankly, finding very little low-risk disease because you don't even get a biopsy anymore without an MRI lesion in the UK. So 80% is probably our target. It's interesting. My conversation with a patient with low risk disease is about a quarter as long now as it was, 10 years ago when I was starting practice, in terms of how much time I spend talking them back from the cliff of treatment for low-risk disease, partly because, I'm more comfortable with it personally, but also because it's less likely that a San Francisco patient who sees me will have had 3 or 4, surgeons and radiation oncologists all primed up and, have already been halfway rushed to treatment. Surveillance is out in the vernacular, at least in our neighborhood, and it's less of a foreign concept to a man to not treat cancer than it was, a number of years ago. So, the need for that reassurance is a little bit less than it was, and a lot of it is how we present things to patients. Now, having said that, it is absolutely a good use of the marker to provide another level of reassurance. But the one caveat there is then there's a big extra variable in the way the information is presented to the patient. And there's an amazing lack of science here, right? I mean, we spend a lot of time doing the analytic validations and planning out these statistical studies and proving that the test has prognostic value. And then the reports get designed by the marketing departments. Maybe with an ad board of community-based urologists, maybe not. Maybe purely with sort of the marketing department. And that's not a thing at the companies. It's just the reality of the way these things get developed. And, like I showed you with the GPS example, sometimes the way the test is presented, even though the science behind the GPS test is perfectly sound, that presentation of the information can actually lead some men to get treatment who don't need it. That guy on the right who had a GPS of 27, you run the numbers, that should be a very reassuring score to him. But because he comes in with that label of unfavorable intermediate, the test can actually lead him to make the wrong decision. So yes, I do use these tests, Decipher for the most part for men who, I don't think they necessarily need it, but it's going to make them feel better and make us feel better. But you really do have to pay attention to how the number is presented.
Dr. Punnen, anything to add to that?
Yeah, I mean, I would echo a lot of that. I think it's exactly like Dr. Cooperberg said. I think how much time he has to spend trying to talk someone off the cliff. And so, if you have a person that's seen multiple people that are saying they need treatment, then yeah, that Decipher test or whatever you're going to get that continues to show low risk is going to be helpful. But I agree that more and more now people are accepting the fact that there are many cancers that are not going to need treatment and they may have that. So I think it very much depends on what they've heard coming and how you portray the information you're going to give. But every little piece of information that you can show that tells this person that their tumor is low risk is going to help.
And maybe Dr. Punnen, for the patients that are coming from outside, or not everyone gets treated at a major academic centers. So do you see these genomic tests as a way to basically level the playing field, where they may be getting diagnosed in a center that doesn't necessarily have a card-carrying member of GU pathology who's trained under some of the greats in the field, and perhaps could have their pathology, especially as it's so dependent on a original Gleason score which spanned 10 now to really being crammed into 5, and really what we're talking about is only really 2, and some of the differentiations are subtle on the pathology. So I'm just curious your thoughts on that.
Yeah, I mean, I think so. There's definitely a potential for these tests to do that. I think there's a number of different tests that can do that. I mean, you can definitely review the pathology that's coming in to make sure that's fine. I do think MRI, especially at that baseline visit, is going to play a big role to get a sense of whether someone had an undersampled gland or not. And then I think these tests can also kind of layer another layer of risk stratification on top of that. That kind of breaks more objective evidence coming back, regardless of any bias in sampling or anything else that came from anywhere else. So they're all helpful. But that's why I think, at least for me in my practice, I do tend to find that there's no one particular thing that I'm going to hang my hat on. And it's really how all these things kind of come together that plays the role.
And Dr. Cooperberg, in terms of thinking about genomics, do you think about it as a single time point, or is this something that you would think to resample as the patient, let's say, had an upgrade on their Gleason score, or if you saw a change in PSA or PSA dynamics?
That's an easy answer. We don't know. There are very few studies out there. We did a study. Peter Carroll at our institution ran a study of serial GPS testing. It came out a year or 2 ago in Journal of Urology. It didn't. The problem is we don't even know what the test-retest stability is. If we ran the same, biopsy the same prostate twice, a week apart, how much variation do we see? So that study did not really validate any notion of biomarker velocity or GPS velocity as a new measure for us. I've certainly run I can think of more patients who have had, say, a GPS or a Polaris from a diagnostic biopsy on the outside, where, at the time of upgrading, maybe we'll get either a repeat or a Decipher on a subsequent biopsy. But it's not part of our routine protocol to do that. We have done it occasionally, again, when we're just on the edge trying to figure out what to do. But there are very few published studies. And like I said, before you really can figure out what to make of biomarker velocity, we need to figure out just how much noise there is around each number. Each time you see a number on a 1 to 100 scale, which is how Decipher is read out, there is an error bar around that, and that does not come out on the report. So before we tell a guy you went from a 46 to 52, especially because the way Decipher is formatted as well, you do have those three risk boxes. And I would be a little worried about somebody, going just from green into yellow and getting too worried about that. We don't know what the stability is yet. We need more studies.
And what are your thoughts, Dr. Punnen, on what's the right endpoint for some of these studies that we've been alluding to? I mean, we know that if you have a man with low-risk disease from PROTECT and other trials, that their likelihood of death from prostate cancer is extremely low. But at the same time, we know that with the large insistence on PSA and the fixation on it, that could be really the main number that patients are thinking about and seeing, and constantly bringing them consternation and worry. So what should we be looking at for active surveillance as the quote right endpoint for these studies?
Yeah, that's a great question. I mean, because for the most part, I think we've been looking at the Gleason score as our endpoint and what considers reclassification or upgrade and what a person gets treated for. But we know that, as Matt mentioned, there's a lot of heterogeneity in how the Gleason score is read out, and we are seeing a lot more adoption of surveillance in favorable intermediate risk patients, and for them, how much 4 is enough? Nobody really knows that. And so, ideally you'd want to have something obviously more absolute, like, likelihood of prostate cancer, METs, things like that. But how you trigger that into when you're going to actually do something in, to the prostate and start treatment there, it's a very difficult thing. So I feel like this is a challenging area, is to think of the right endpoint that these markers need to try to power to. I totally appreciate, metastasis being one that, like, Decipher and others have done, but it's also hard to, communicate that endpoint to a lot of patients who find that hard to kind of project when they're just asking, should I get treated or not at this point? So yeah, I don't have a great answer to that question, but I don't think it's Gleason score, which is what we've been doing a lot, for.
I would agree. It's a really challenging question. I just want to chime in there too, because I think I alluded to this in the slides. We're really starting to focus a little bit more on negative predictive value for these tests, because, and I'm saying this as someone who's done a bunch of studies with adverse pathology as the endpoint or grade reclassification as the endpoint, and it is a big challenge. However, I think what we're learning, or at least starting to appreciate, maybe we always knew it, is that adverse pathology, maybe it's bad, maybe it's not. Some of those men will progress to MET, some of them will not. Likewise, a grade reclassification on biopsy, maybe that means something, maybe it doesn't. But if you don't have that event, you are pretty much in good shape. So, you tell me I have maybe a little 3-4 in the prostate. Maybe I need to think differently about that. Maybe I don't. But if you tell me with greater assurance that all I've got is 3-3, like I said at the beginning, that's a prostate I'm not worried about. Likewise, after surgery, a little bit of T3, maybe it matters, maybe it doesn't. But if you've got a T2 Gleason grade group 2 tumor, on RP, you really should be pretty much set for the duration. So starting to rethink about, now you need different study designs, and you often need larger cohorts, certainly longer follow-up to try to get at some of these study designs. But I think we're starting to evolve that way in planning the next generation of studies, hopefully.
Maybe I'll end on this question. Given this past year with COVID and the lack of resources that we've had, you have in 90 hours in a week, 120 hours in a week that you have to see patients. And, you're going to have patients that you're going to be operating on, patients that you're going to be seeing over active surveillance. And especially what I think COVID highlighted to so many of us is that we really have to be prudent and cogent about how we surveil patients, how we utilize them, how we fill those follow-up slots, so that we don't potentially expose patients to unnecessary visits, because that breeds within itself a lot of consternation on the patient's point, but also to make sure that we're actually seeing the right patient at the right time interval. So I think COVID really kind of put the spotlight on that. And given that we're talking on active surveillance and genomics, just kind of get your thoughts on how this comes into play for us.
No, I see what you're saying. So I think, for me, I could tell you, I get a lot of emails and texts from my residents asking me what's my, active surveillance protocol for everybody. And I say, I don't have an active surveillance protocol for everybody. It depends on how it is. So I think the use of some of the things that we've discussed today, markers, imaging, other things like that, to have a very good upfront baseline risk assessment can really kind of bring home, as Dr. Cooperberg mentioned, those guys that maybe in that 10% that need very intense follow-up if they want to choose to do surveillance because they need to be watched very closely to not miss that window of cure, versus that, I think it was 40-50% of guys that really are okay, and you can say that, and I think Matt's point about negative predictive value, and you can take back the data and say, look, for these well-done trials, there's lots of follow-up and thousands of guys who look like you really were fine for decades, I'll see you in a few years. That's kind of thing what we'd like to do.
And ideally, a lot of this management, I think one of the silver linings that everyone, of course, has talked about with COVID is that telehealth is going to be here to stay. And, we don't need to see these patients in person nearly as often as we traditionally have. PSAs, of course, can be done anywhere. Biomarkers can be arranged from, anywhere remotely. So, MRI, I believe, is still very center dependent. We do drag men down for UCSF specific MR. Unless they've come from another academic institution, at least. So, but I think, we're certainly evolving to a scenario where they really only need to come in person every 2 years, or maybe even less frequently. And patients like that. I mean, as much as we miss all the personal contact, and I still miss seeing new patients in person, our catchment is pretty wide, and folks love not driving 3 hours for a 10-minute, you're fine sort of active surveillance. So.
Well, this has been excellent. I'd like to thank you both so very much for your time and attention and your ability to distill a very complex issue into a very easy way for us to follow. So thank you both very, very much.
Great.
Thanks for having us.
Great to see you guys.